All right. Thank you, everybody, for coming to the new edition of the Florida Healthcare Simulation Alliance webinar for December. Today, we have the pleasure to have a topic on leadership, leading with love and high reliability. Our speaker today present is Cindy Price, and I will pass it to her so can introduce the members that will participating on this project. Go ahead, Cindy.
Hi, so we did a webinar and it was given at the University of Lahore in Pakistan. And our other contributing authors were Bob Ronska, who is Navy Bob, who worked on the with President Bush in the White House, carried the nuclear football, and he also manned several submarines as the Marine captain, our Navy captain, and then also working with Sajid, Dr. Sajid Hameed at University of Lahore and Green University. So that's who we worked with on this webinar. We'd love to share it with you today, and it's about simulation and leadership. Should I take myself off video so you can minimize me and maximize that one?
Hi, everyone. I welcome you all on today's webinar, Leading with Love, a high reliability leadership series. And I am delighted to be moderating this event and to introduce my esteemed speakers, Dr. Robert Navy Bob Ronska and Cindy Price. This webinar is in collaboration with Dr. Robert Navy Bob Ronska, Johns Hopkins University School of Nursing, and the Department of Public Health, Green International University. I am honored to bring together these distinguished institutions and the expert to explore the need of leadership and the role of love and compassion for fostering the high reliability and effective leadership. Before jumping into and giving the full introduction of our very respectable and esteemed guest speakers, I would like to shed some light on my part, which is the leadership for better health with a focus on the developing countries. My name is Dr. Sajid, and I am Associate Professor and Founding Chair, Department of Public Health, Faculty of Medicine and Allied Health Sciences, Green International University. So I chose this topic because, in my opinion, in developing countries, the settings are very resource limited, and there is always need that the health outcome should be better. The first question arises is why leadership is most needed in developing countries. There could be many factors, and we can discuss it a lot, but to summarize, in my opinion, there are a few factors which we can summarize, and I will shortly discuss with you. The number one is the lack of processes, protocol, and the systems. In developing countries, there is no, of course, like in Pakistan, there is lack of processes, and there is no system in place, and there is no protocol, and the system do not know how to behave when some situation arises. So this create the need for the leader and the leadership. If the system and if there is a system, if some situation arises, it will address by itself, and the system will go on if the leader is there or not. But if there is no system in place and if there is no processes, there is always a need of the leader, and the persons facing that situation will always look for somebody who can guide them, and it increases the need for the leadership. And on the other side, if there is a leader there, he definitely will establish the system and the processes and the protocols for the standardization and for the standardization of the care. Second is high burden of problems and unexpected situations. In most of the developing countries, the burden of the problems and the disease is very high. And like in Pakistan, we always face the double burden of disease. For example, we have the malnutrition and we also have the obesity. We have the diabetes and we have the ischemic heart disease. So we are addressing one issue of communicable diseases and infectious disease, and we are also facing a high burden of non-communicable diseases. So this is a very challenging situation, and the situation is always very volatile and unexpected. I can say, and I can mention here, the situation is politically motivated and it's not very stable. If somebody comes in and he establishes some protocol, and if he tries to build something, but he could not implement it because there is a lot of political instability. The third factor is there is no structured training. Though there is a great need for the leadership, but there is no structured training for the leadership. We need a lot, and we need a very good leader that they can address those issues, and they can build the systems and processes. They can lower down the burden of the disease and the problem, and they can stabilize the system, but there is no structured training. So these are the main three causes which increases the need of the leadership in the resource limited settings and in the development. The second part is, what are the challenges which are faced by the leaders, especially in the developing countries? Of course, there is no one fit solution, and the situation is and the solution to the problem is always contextualized. The number one problem is very obvious. The resources are limited, but the needs and the demands are more. The infrastructure is not very supportive, and there is lack of infrastructure which is not supporting to achieving the desired outcome. There is a high burden of non-communicable diseases, and there is also a high burden of infectious diseases. The other issues are there is a shortage of workforce, and there is also a shortage of trained health professionals. If the health professionals are not trained, and if they are not trained on the vertex of healthcare quality, how to address, how to give a standardized care, and then the problems will arise. The issues like the medical errors will arise. We were discussing in our previous sessions that what is the magnitude of medical errors. Even I cannot tell. We haven't measured the burden of medical errors in my country. So this situation is quite alarming, that even we do not know the magnitude of the problem. The political instability, as I mentioned earlier, it's the health priorities and the health system could not be implemented, and the policies could not be carried out if there is not political stability. The other problem is the cultural barriers. Social and the cultural factors always very important whenever we want to address some issues. So the strategy should be contextualized, and it should be socially and culturally acceptable. So it's very important to consider these factors whenever we want to address the issues in some specific area. We have discussed that why leadership is more needed in developing countries. Then I touched that what are the challenges which are needed in developing countries. And now I want to talk about that, what to do, how we can strengthen and how we can strategize the health leadership, especially in the context of the developing countries. Of course, investing in leadership training and program. It's very important to develop a tailored training program and equip the healthcare professionals with the leadership skills. This is an effort towards this, that we all get together and we are trying to make and sensitize our colleagues and the healthcare providers and the policymakers that this is the need and this is how we can address the issues. And I'm very thankful to our speakers that they have spared their time, and we are trying to achieve this thing, and we are trying to sensitize our colleagues that this is the main problem where we can start, and this will be the right start, and that this will be the right direction. Mentorship and peer learning, this is the same, which I just talked about. As leadership is important, so the followership is also very important. So that's why we need to create a culture, and we need to work on this, the mentorship and the peer learning. Building network and partnerships is again the same what we are doing now, that we are trying to build the partnership locally, regionally, and global partnership for the resource sharing and capacity building and knowledge sharing. This is what exactly we are doing at the moment. This is very important. If you do not have some skill set, if you could not develop something, there is no harm, and there is no shame to ask for help and to ask the others who are expert in those areas. The other thing is emphasizing on the evidence-based decision making. This is very important to work on the data, to have evidence-based decision making, and to partner whenever we want to make some decision. We need to partner with the stakeholders, and we need to engage the community to make it more sustainable and to make it more socially and culturally accepted. Except all this, what I have discussed, our focus should be on preventive health. Why on preventive health? It's not possible to lower the burden of the disease if we do not focus on the preventive health. In the countries like mine, the government and the policy maker, they are more focused on establishing the tertiary care hospitals, and they have less focus on the preventive side. So our focus should be on not building the hospital and closing the existing hospital rather than building a new tertiary care hospital. Then digital health leadership, this is also very important. Without the technology, we could not go on, we could not measure the burden of the disease. For example, in our healthcare systems, the HIMS is in place there, but it's not working on their full potential. We are not gathering the data on real manner, and we are not taking advantage of the data which is being collected. If it is collected, we are not taking the real advantage. We are not making any strategies based on the available data. We are not predicting the diseases, what data we have. So first thing, we do not have a health system which is fully very well equipped with the HIMS or the digitally well equipped. And though if we partially have, and we are not benefiting out of it. Other is the global health leadership and the sustainable leadership practices. This is also very important. if we adopt some practices and we do not consider the local context, then it will not be sustainable. So it's very important to consider other factors and to bridge it with the local context and the local culture for the sustainability and for the acceptability purposes. So we will have the question, we will have some time at the end, and the audience can ask the questions. So this is all from my side. And now I will request Dr. Robert Navy Bob Ronska to share his experience. But before doing that, I would like to introduce him briefly. I will have the honor to introduce him. Dr. Robert Navy Bob Ronska has an impressive background and diverse range of experiences. He has held various leadership positions in both the military and civilian sectors, focusing on leadership, safety, health, and high reliability. After retiring as a Navy captain in 2018, Bob joined Advent Health Central Florida Division South Hospital as the executive director for patient safety. He subsequently took on roles as the corporate executive director for high reliability and unit culture, and later as the CFD Radiation Safety Executive Director. He served as an adjunct professor at the University of Central Florida's School of Global Health Management and Informatics, teaching graduates level courses. Prior to his civilian career, Bob had a distinguished 28 years career in the US Navy. He served as the Pacific Fleet's top fast-attack submarine commodore, overseeing 10 Los Angeles-class nuclear submarine and leading over 1,700 personnel with assets and the budget exceeding $25 billion. Responsible for overseeing numerous unprecedented missions vital to national security. Bob's military career also includes serving as a naval aide to the President of the United States, where he was responsible for the safety of the office of the President and handled extremely sensitive national security program while carrying the nuclear football. He was warmly dubbed as Navy Bob by the 43rd President George W. Bush. Bob holds an executive doctorate of business administration from the Kramer Graduate School of Business at Rollins College. I warmly welcome you, Dr. Robert Navy Bob Ronska, and have the pleasure to give you and share your thoughts and experiences with us.
So, Dr. Sajid, I really appreciate this. This is such a privilege and honor, and thank you, Cindy and Mariano, as well, for your leadership. It's just a privilege to be here. And so, as Doctor said, that I spent 28 years in the nuclear Navy, and the American nuclear Navy is known for its high reliability standards. We've gone over 75 years, and we have not had a reactor accident. And we got 20-year-old sailors at the helm operating these highly enriched nuclear reactors, and we've never had a reactor accident. So this is why the nuclear Navy is known for its high reliability throughout the entire world. And so is this something that we need in healthcare? So that's where I got into healthcare. Even in America, we're talking about a developing country. The third leading cause of death in America is due to medical errors. So even though we have great leadership, we have great technical opportunities and advancements and processes, we still struggle with safety. And my aha moment is you can't have one without the other. Leadership is so essential for high reliability. And so I want to take you on a journey and tell you about my experience when I was the captain of a $2 billion Virginia-class nuclear submarine. And so if you would go to the next slide, this is a picture of the nuclear submarine. And I want to paint a picture of why leadership is so important. Even though we had these high standards in the nuclear Navy, we still, as Dr. Sajid said, is that we have a high burden of problems with unexpected situations. And so in 2009, I was tasked as the commanding officer, just relieving, to take this new Virginia class nuclear submarine underneath the North Pole to certify this new class of submarines to certify it for Arctic operations. And some of the dangers associated with going underneath the North Pole is that it's 28-degree, you're surrounded by 28-degree water, and all the condensation comes out. And it's like a rainforest in the engine room. And these unexpected droplets of water are landing on these highly energized panels, cabinets that contain microprocessors that control the reactor. And if you lose the reactor, and sometimes it was days before you could surface before the ice was thin enough, you would die if you couldn't get the reactor back up. Next thing we were doing, we were dodging adversary submarines. They were trying to come out and try to find us. And we were navigating our way through the iceberg capital of the world, the Denmark Strait, the same strait that produced the iceberg that sank the Titanic. But I wasn't concerned about the ice. I wasn't concerned about the adversary submarines. I wasn't concerned about the icebergs. What concerned me the most was this culture, the culture. Even though we had the highest reliable organization, the processes in place and so forth, that I would love to share with those processes in healthcare that I learned, but it wasn't enough. The leadership training was essential. And so what I did is that I knew that we had this high burden of problems. It was like playing this game whack-a-mole. Every day, it was not if, it was when and where we'd have another issue. And it was unbelievably more prevalent on this ship than any other experience that I've had in my 28 years of nuclear Navy. So what did I do? I pulled out my toolkit of improving culture and leadership. So I mustered the crew topside, and I printed out a piece of paper that had the name 1, 2, 3. That's all I had. I went in front of my crew of 160 at the time. I said, please let me know what your concerns are. I said, I don't want to burden you. If you have nothing, just put your name at the top. Take 5 seconds to put your name at the top so we have 100% accountability. And I says, but if you have anything, I love you, I care for you, I need to know what your burdens are. And I was only in command of this submarine for a month. And I went back to the ship, and they collected the 160 responses, and I was shocked. I had a stack of paper like this of concerns, and I had a pit in my stomach. I started feeling nauseous, and some of the things that they were concerning to them is that we didn't have enough computers on board this $2 billion nuclear submarine. Clearly, this $2 billion submarine can afford computers, but half of them were broken. And what that entailed was about 2 hours per sailor per day were wasted on the inefficiencies of not having enough computers. And that meant that they couldn't be with their families after they needed to go home. And so the light bulb went off on me. It was, I know now why we're playing whack-a-mole. I understood now why we had such a high burden of problems with unexpected situations. The reason is because the crew didn't care for this ship or the organization. And why was that? It's because they felt the organization and ship didn't care for them. So I immediately, that afternoon, went up and purchased or got new computers. And I went to other ship, I borrowed it, and I mustered the crew topside again in about 3 hours. They all mustered up topside, and I said, I am so sorry. I love you. I care for you. I had no idea that you were struggling with these barriers. This will never happen again. I got new computers, and this will never happen again. So if you go to the next slide, that was the spark. This was the spark. This is me and the crew at the North Pole. About 3 months later, we successfully navigated this. And we became the #1 ship in a squadron of 10, which was really hard to do. We went from last, we went to first in about 2 years. We had the lowest turnover in the Pacific Fleet of all the submarines for 2 consecutive years in a row. And a major engineering inspection that we almost failed, we got the highest grade possible on that exam about 2 years later. And it wasn't me because I was this gifted technical person or I was a great tactician. All I did was concentrate on the authentic relationships and care for the individuals, and the results went off like unbelievable. And so this is where the crew, the culture, this is where it changed. It happened about here. About 3 months into this process where they felt like they were cared for, they were loved, they were no longer fearful of making a mistake because they were fearful of getting in trouble. They were fearful of making a mistake because they didn't want to disappoint the crew or organization that cared for them. And when that occurs in any organization, that inflection point of that culture shift, you will see your outcomes exceed all expectations. The resources that you have that we showed earlier about you don't have enough resources and the demands, what you're going to do is have outcomes go up so much that those resources will far exceed the demands that you need because you are investing, you are implementing, you are tapping into the greatest resource that any organization has, and it's its people. And so at the end, and I will share this, I would love to share the crew top 3 and what it does. The crew top 3 of something simple, of many other tools in the toolbox. What's soliciting the crew top 3, and I'll give you some data, is that McKinsey did an article, one of the most research publications across 10 different countries. And when they did this research, they asked the people in hundreds of thousands of people in other industries, what is the number one reason why you're leaving? And a lot of organizations thought it was because of price or pay, and it wasn't. They didn't feel valued. And when you do the crew top 3 and you specifically ask, what are your concerns? How can I help you? And you follow up with your words with actions, you're going to start feeling valued. And so that is what the crew top 3 does. It provides psychological safety because you have this mental exercise to be able to solicit input. And you also provide transparency. I would never got caught off not having computers again. I continue this all the way to the end. Do you know what the number one concern was at the end of my time? I did this every month for 3 years, and the stack went from this to one thing and one thing only. And if you go to the next slide, this was their number one concern. There wasn't sufficient variety of hot sauces on the cafeteria. And when you get to that magical concern, that this is the only concern your team has, you have a magical culture and you're going to see your outcomes go up. So leading with love, there are no downsides. Leading with love, all your outcomes will exceed all expectations to include safety, retention, outcomes, productivity, you name it, it goes up. And you'll become a legendary leader and you will build a legendary culture. And this is based on over 50 years of academic research. I studied leadership in my doctorate dissertation, and the theory is called leader-member exchange. And this is 50 years of academic research that shows if you build the relationships within your organization, meta-analysis, evidence-based research shows that all your outcomes can. This is what I want to share. So if you go to the next slide, a famous person that led with love, his name is Mr. Rogers. He has he's known for his incredible passion to help others. And Mr. Rogers has this famous quote that I love, and he's an alma mater of where I went to college at Rollins College and where I got my doctorate. He says, love and success, always in that order. It's that simple, but that difficult. What he means by that, just like I did on the USS Texas, I put love first. The concern, I made the crew the number one priority, and that is where success followed. I loved the crew and they knew it, and we built this incredible organization, and success will definitely follow. There's over 50 years of academic up your
Mario.
words with action
Okay.
and following and having good intentions. So trust, it's really important to understand this. Trust is defined as having good intentions, which you will when you lead with love. But you as a leader, one of the most important things you can do is to follow up your words with action. Even if you can't fix something, you got to tell your team members how you're going to mitigate it. Or if you can't, why you can't do it. It's okay if you can't fix everything. And when you do that, building trust over time, and that's what I did on my ship. And this happens, this can occur in any organization, it's universal. Look at this HBR article, The Neuroscience of Trust. If you want less stress, if you want less burnout, which affects safety, which affects outcomes, fewer sick days, more life satisfaction, you as a leader, concentrate on trust. There's evidence-based leadership practice here that if you want to improve your organization, trust is the key. So with that said, I couldn't be more excited to share not only the high reliability secrets of the nuclear Navy to implement into healthcare, but you can't just do it by implementing practices and procedures. You have to do it with love and leadership. And so this is a combination that I really think that it's not only going to benefit you and your incredible organization, but it's going to benefit us here in the United States. So thank you so much for this opportunity, and I'll turn it back over to you, Dr. Sajid. And again, it's such an honor and privilege to be here.
Thank you very much, Dr. Robert. Thank you very much to sharing your experiences and giving time. So I will have the privilege, we all have the privilege to hear from Cindy Price. Cindy Price brings over 25 years of experience working as nurse educator and leader in intensive care unit and post-anesthesia care unit. She joined the medical simulation and training team at Advent Health in 2016. She received her Master of Sciences in Medical and Healthcare Simulation from Drexel University in 2018, her Bachelor of Sciences in Nursing from Adventist University in 2015, and her Diploma Nursing degree in 1999 from BB School of Nursing. She chaired the Florida Healthcare Simulation Alliance non-affinity group from 2019 to 2023. Cindy enjoys presenting as a subject matter expert and keynote speaker on simulation training at international medical conferences. She also volunteers as a SME on American Association of College of Nurses subcommittee developing nursing essential simulations. Cindy brings multiple years of experience implementing simulation training at multiple hospital campuses and universities, supporting educators while successfully and effectively teaching students with diverse clinical backgrounds and differing levels of care in the medical field. Cindy was instrumental in the development, design, execution, and implementation of simulation scenarios as the department's senior simulation learning strategist. Cindy joined the Johns Hopkins University School of Nursing as the Associate Director of Simulation Education. She loves to bring others joy. She shares her Labradoodle therapy dog, Bobo, with patients and the healthcare providers at the hospital and community events. I welcome you, Cindy Price, and give you the floors to share your thoughts with us.
Thank you. It's such an honor to present with you and Navy Bob today. And thank you, Mariano, for hosting us. I'm really excited to have this platform and speak about simulation and how we have incorporated simulation into leadership training. So the big question is, why do we use simulation in leadership training? So what we noticed was that when we do a lot of leadership training, we technically do it in didactic format. So we are giving them the tools in their tool belt, and we're boring them with PowerPoints and talking to them, but then we weren't giving them the opportunity to practice or to apply what they were learning. Oftentimes we've noticed in leadership in healthcare that, oh, you've been on the floor for a long time. You're the most senior person here. You're now the leader. Thanks for doing it. But we don't give you any, we don't really teach you how to do it. So that's something that is often recognized in healthcare. So we saw this and we saw the opportunity of, okay, how can we assist them? So we wanted to follow up with those application trainings. So we brought in our subject matter experts in leadership together. And first they had developed a corporate playbook. So they got together with all of their policy and procedures, and they developed the playbook, and then they had started launching didactic training. So they brought us in about midpoint of didactic training and said, okay, we've highlighted things within the didactic training that we would like them to practice hands-on. So we got really excited, we got together, and then we started developing our role play scenarios for simulation. We came up with 5 different simulations that I'd like to share with you today. So as we were going through our simulation, we needed to identify and mitigate the risk that were happening within our organization. So not only with the high reliability in healthcare, but also how we interacted and gained that trust and created that psychological safety within our team members. Next slide, please. So during our needs assessment, we recognized what they did well, and then we recognized what we could help them with. So we noticed that they did a great job identifying latent patient safety risk or errors that happened within their organization. And then we noticed that they took a lot of time to really speak with their team members, but they didn't really have a focus during their conversations, or it didn't always come off the way that that they needed it to have that structured conversation. So those are things that we saw we could help them with. So what we wanted to work with them was, okay, this is the root cause of your error. And so what type of harm actually happened? And then how can we mitigate that? How can we make this better? How can we identify that risk? So they would often say, oh, a wrong medication was given. But why was that wrong medication given? What was the process that nurse followed? You know, did they follow the 5 rights of giving that medication, or were they interrupted because maybe it was a busy time frame and they were interrupted in the middle of those 5 rights? So we really wanted them to say, okay, this happened, but why did this happen? So we wanted to give them the tools in their toolbox to become a more efficient leader. We also noticed that with the unstructured conversations, they just, nurses are often very empathetic and very compassionate, but we needed to follow up with that of you can be empathetic and compassionate. We love that and we need that in nursing. But as a leader, we also need to be able to structure those conversations to have an end result. So that was something we're extremely nice leaders in nursing. So we needed to give them more emphasis on how to identify those structured conversations and how to get an end result. And then that does follow up with the effective feedback as well. And then we also wanted them to, we wanted them to create that empathetic and to feel psychologically safe. We didn't want anyone to feel defensive. We didn't, be curious as you're learning about the root cause of these conversations. And then also creating that psychologically safe environment amongst your team members. So those are things that we practiced during our simulation, and I'm going to break them down for you now. The first simulation that we did was a de-escalation between healthcare providers. So here, what happens frequently, and when I worked with each one of these subject matter experts to identify these simulations, they took real life scenarios and we recreated them. So we did have a certain surgeon that worked within our healthcare organization that was often frustrated with the nursing care, and like if his orders weren't carried out correctly, he would raise his voice with the nursing staff, and didn't want to really hear their side of it, just became angry. So the leaders within these units oh, that's just the way that he acts. Oh, it's okay. He'll yell at you and walk away. Maybe he'll be nice to you tomorrow. So we needed to recognize within an organization, that's not right. And, we shouldn't take verbal abuse from someone who's in a higher ranking role than us. We need to empower them to be able to speak up and to be able to be talked to in a nice manner and not accept the verbal abuse from another person. So the nurses had all accepted this, that it was normal, it was okay, but we wanted to give them the strength that no, it's not okay, and you can stand up for yourself. And as a leader, we need you to stand up for your team as well. So we practiced conflict resolution. We highlighted it within the policy and procedures of our hospital, and then we allowed them to role play. So we brought in our actors, and we actually had our physician in the white coat, and we had, their name badges on and everything, and we would start to see them cower. So we did rapid cycle deliberate practice simulation with them, where we'd be like, stop. I noticed you did this intervention. I would have expected you to do this intervention. And then so we would stop that role playing, give them the confidence and the tools. Say, okay, now I'd like you to go in there again. You're going to be confident. You're going to stop this verbal abuse. And then you're going to pull the doctor away and you're going to get his side of the story, get the nurse's side of the story, bring them back together. And then we're going to resolve this conflict. So we did that until our leaders felt comfortable. So that's another way that we can promote that psychological safety within our environments and also build up that nursing team. The next one that we did was we identified corrective action. So within the leadership training, they had lots of forms that they had to fill out if something happened on the unit. So we recreated a simulation where we had a nurse caring for her elderly parents, and they had become very sick. So unfortunately, the nurse missed a day of work because she missed her schedule, and she was actually at a doctor's appointment with her elderly parents. So then they called her during her appointment and said, "Why aren't you at work today?" And she became flustered and didn't realize that she missed a day of work. So the nurses, being very empathetic, allowed this to happen over and over again. But then it was hurting the team, because then the team couldn't take care of their, they were down a nurse. And it's okay, because Sally's taking care of her parents. So I just need to take on more patients today because Sally couldn't make it in today. So we needed to do corrective action, but also do it in an empathetic manner. Like, we know that you have circumstances at home, but you also have responsibilities here at work. So giving the nurse the tools in their toolbox to utilize that corrective action form, but also follow the policy and procedures of the hospital, and also offer resources to that healthcare provider of how can we help you? We recognize this is happening and that you have a lot of other responsibilities besides work, and how can we help you? So we also took that empathy in there. As a nursing team, we are very empathetic, and how can we support you? But also, how can we support the rest of our unit and not allow this to continue to happen? So that was a really great one that brought up a lot of debriefing as well. And, oh, I feel guilty for counseling her, but this is how it affects the rest of your unit. So building that trust, building that high reliability within your unit as well. The next simulation that we did was addressing unsafe care in the moment. So what they had seen was the nurses would go around in their leadership roles, and they would go to each individual patient every morning and check on them and see how their night went, what they could do for them in the hospital, how was their care going so far, and how could we make it better for them. There was a nurse doing her rounds, and she noticed a new graduate nurse come in, and she was a little flustered, and she noticed her getting ready to administer a flu shot intravenously versus intramuscular. And the patient was also a little concerned, like, I've never gotten a flu shot in my IV before. So how do we still ensure that that patient stays safe, but not break down that nurse, build up that nurse in front of the patient? So this was a great simulation where we stopped the situation from happening, but also coached up the nurse while ensuring that the patient was safe as well. And then that led to that nurse leader having those conversations with the patient as well, to promote that psychological safety, like, it's okay, we're here to take great care of you. So that was also a really great simulation. And, we didn't put down the nurse in front of the patient. We supported that nurse in front of the patient, even though we stopped a crucial, patient safety error from happening as well. The next one that I'd like to talk about is diversion training. So within the United States, there is a high level of diversion. And what we mean by that is narcotic discrepancy. So what we did was we actually, we have our Pyxis machines where you do a thumbprint, and it links back to that individual nurse, pulls individual narcotics or medications for their patient. We run weekly reports so you can see what medications are given and then what is wasted within there as well. We created the simulation where we noticed a discrepancy and we noticed a pattern of behavior where they were pulling out more medications than prescribed, and then they weren't wasting the medications appropriately. So we created a simulation of something that had actually happened. It was a nurse that was diverting narcotics to herself. And the other thing that happens within this culture is that with your nursing license in the United States, we know that if we don't report a diversion, we could lose our license as well as that nurse lose her license. So it's very much that culture of, I don't want to get in trouble, and I also need to support my fellow nurses, but then I don't want to tell on them or tattle on them. So how do you identify this and also support the unit as well? So we had it where the nurse leader identified it. She went through all the proper channels and followed the policy and procedures, and also offered the resources that the hospital offers for this, for a diversion or a drug addiction that they may have. And then also going back and talking to the unit. So we know that you probably recognize this pattern of behavior. Thank you for bringing it to our attention, and we're here to support everyone. And if anyone is overwhelmed within their role, how can we help you? So to help prevent any other narcotic diversion as well. So those are the simulation trainings that I wanted to share with you. It really takes group effort to come together to identify what simulations should be added to a program to support the didactic training, and we align everything with the goals and the objectives. And then when we do our debriefings, we also embed each objective of that simulation into the debriefing format. So you're closing all gaps of knowledge is something that's really important with simulation as well. So that's all I wanted to share with you. And if there's any questions, I'd love to answer them for you now.
So thank you very much, Cindy. All the participants can ask the questions later on, and we will try our best to answer all these questions. So I would like to thank you, everyone. And I would like to extend my deepest gratitude to our esteemed speaker, Robert Navy Bobronska, and Cindy Price and Mariano, who give us support in arranging this meeting, and the speakers, to the speakers for sharing their invaluable expertise and experiences with us today. And I also thank you to the participants and all those who contributed towards today's discussion. And this is just the beginning of our journey through this series, and we look forward to seeing you all in the future sessions. So thank you very much once again for all those who contributed in this webinar. See you again.
All right. So let's see. Okay. So I wanna. Do you have any questions? Any the participants have any questions on that?
Hi, Cindy. Thanks so much for that, sharing that presentation. I was really interested in maybe hearing a little bit more about that diversion simulation, because that, sometimes we feel like a kid in a candy store, and there's so many things that we could cover, applying everything that we've learned about simulation. Tell me more about that, because I think that it's really sparking some ideas that we might be able to apply, not maybe the traditional straight clinical experience, but establishing something like this. And then obviously, how does that lead then to leadership concepts to be able to implement in maybe what we do in a more traditional, if you will, manner?
Absolutely. So the pre-learning to the leadership training was everything was aligned with a corporate playbook. So the leadership team had actually gone through the corporate training first, and they had done it was a series of didactic and remote learning. And then so when they came to the simulations, they actually had all the resources in front of them. So when they identified, that it was diversion, then they could go to the computer and then pull up all the resources for diversion. So they really liked the application piece of it because they received so much information. And we started with our new assistant nurse managers, and then we added in all of our managers and assistant nurse managers that missed training during COVID. So it was really great. The assistant nurse managers were going back and saying, "Hey, did you know we had all these resources?" And then the managers who were hired during COVID, like, "No, we didn't." So it was the newer employees were helping the experienced employees. So they really liked that application. And then also with the debriefing, it opened it up to, hey, I've had to have these conversations about diversion as well, and then it, what are some tips and tricks that you did? And then what can we not do? I can't search their bag, right? So it led to a lot of great questions. But yeah, everything was linked back to the policy and procedures, and then having all those resources readily available for them. I think was an opening up for that debriefing, for that forum for them to speak through.
Any other questions? Well, I just want to thank everybody. I just want to thank everybody for coming up for this webinar. I just want to invite future speakers to please reach out and send us a proposal to host another webinar in the future. And also want to invite everybody that is going to IMSH that the FSH is going to have a meeting on Monday at 7 in the morning. I forgot from top of my head what room is going to be, but I'll be sending an email invitation to everybody to please come up. We will have coffee and pastries since it's 7 in the morning. So once again, thank you for coming. Thank you, Cindy. Thank you for Lady Bob to help us, and Sajid for the wonderful topic on leadership, especially leading with love. Okay, have a great day, everyone. Thank you.
Yeah. Hey, Mariano, would you be able to send out on our LinkedIn page, the FHSA LinkedIn page, like where that meeting will be?